Dear colleagues, fellow nephrologists, ladies and gentlemen, welcome to Live 2021 Nephrology Campus. My name is Christoph Wanner. I'm a professor of medicine at the University of Wuerzburg, and I'm chairing the webinars together with my colleagues, Professor Peter Stenwinkel from the Karolinska Institute in Stockholm. Today we have webinar number 15 out of a series of 18 webinars we are chairing under the Live 2021 Nephrology Campus. And the topic is today, under current trends of nephrology, is COVID-19. You as the participants, you are automatically muted and invisible, but you can ask questions anytime and put your questions in the box on the right bottom corner, and we can answer at the final end all your questions. Today we have two eminent speakers with us. First, Professor Anette Bruchfeld. She is head of nephrology at the University of Linköping in Sweden, and Professor Ron Gansevoort from the University Medical Center in Groningen, the Netherlands. So let's start with our first talk of Professor Anette Bruchfeld under the title COVID-19 infections, implications for nephrology and vaccine preparedness. Please, Anette, the floor is yours.
Thank you, Professor Wanner. So this infection hit the world a year and a half ago, and we have spent a lot of time trying to control it in different ways, mitigation strategies, lockdown strategies, and so on. The vast majority of patients have mild to moderate disease, but there is a number of patients that have severe disease and also critical disease. So at the beginning, the disease manifestations were recorded as being pneumonia with fever, but it turned out that this was a more multi-organ disease, and that this virus damages tissues and organs via various mechanisms, uncontrolled inflammation, activation of the coagulation and complement system, endothelial damage, and multi-organ dysfunction or failure. And patients who've been hospitalized and in the ICU, they need time to recuperate. But there's also a new phenomenon of this long COVID or post-acute COVID syndrome, which is a new disease entity of patients who might even have mild disease and still have long-term symptoms. So there are a number of manifestations of different parts of the body, as you can see here in this cartoon from Nature. And it was early shown that CKD is a risk factor for severe COVID-19. And the biggest study is from the UK with 17 million patients with available electronic health records, the so-called Open Safely study. And it was shown that CKD patients with a GFR less than 30 and organ transplant recipients had a high risk of hazard ratio of 2 to 3.5 by multivariate analysis of COVID-related death. And it was also shown that there was some ethnical risk correlated with ethnicity, which really is more a sign of that deprivation is an important factor here, and socioeconomic factors are important, as it's always been in all the pandemics up to date. This is also a Danish study showing a countrywide study showing that the risk of severe COVID and mortality is increased even in the patients with CKD2 already, not only for CKD patients 4 or 5. The acute kidney injury that is found in these patients is fairly prominent, and the mechanisms are different and probably combined, combination or influence of fluid balance disturbances leading to pre-renal AKI, toxic tubular damage following this cytokine storm or rhabdomyolysis, angiotensin II pathway activation, virus-mediated injury, endotheliitis, thrombotic event, intravascular coagulation, and also organ crosstalk between the lungs and the kidneys, the heart and the kidneys, and drug nephrotoxicity. Looking at patients who have been hospitalized with COVID-19 and acute kidney injury, this is a study from New York, 13 hospitals, and it shows that acute kidney injury in hospitalized patients is associated with significant risk for death, and especially in patients who need kidney replacement therapy, the risk increases even further. And in this US study of the AKI patients who needed kidney replacement therapy, 13.6% of patients remained on dialysis upon discharge. And this needs to be followed further to see if this is a problem that remains or if we have a new set of patients that we didn't expect. Pre-existing CKD is an independent risk factor for dialysis dependency at discharge in this study. We have looked also at specific risk categories here. This is from Stockholm, the geriatric material of patients hospitalized during March to June of last year, and a third of the patients with COVID-19. And this is interesting because the same amount of women, or perhaps even more women, who are hospitalized because they're older, of course, but the discrimination between gender here is not as big as in younger ages where the men have a higher risk. So here, just to point out that this is a really strong risk category. If patients, geriatric patients had AKI and COVID-19, the odds ratio to die was 80 as compared to COVID-19 without AKI and AKI without COVID-19. As for the consequences, for the long-term outcome, we have to follow this. This is a study from China looking at patients 6 months after discharge from hospital, and then they have all sorts of symptoms, not all of them, but prominent in some patients of sleep difficulties, anxiety, depression, and there are also some pulmonary symptoms that remain. But looking at it from a renal point of view, of patients with an available EGFR history, 35% had decreased EGFR at 6-month follow-up. And here in China, this is Chinese study, the number of acute kidney injury patients was much lower than as is reported from other countries. But here you find that patients without AKI and with the normal EGFR, of those 13% had decreased EGFR after 6 months. And so we really need to follow this carefully, this story. Regarding treatment, I'm not going to say much, but we have these different phases, viral response phase and inflammatory phase, and the studies that have shown that immunosuppression plays a role here, which is the dexamethasone study from the recovery trial, and also tocilizumab or IL-6 inhibitors have shown some effect on patients who have severe disease with dependent on oxygen. And it has also been shown that giving dexamethasone reduces the risk of acute kidney injury, which is a good sign. So we have looked at these different cohorts in various countries. This is just a publication from Stockholm. We had a 23% mortality in our Stockholm area in hemodialysis and peritoneal dialysis patients, of infected patients. And this is the study, the ERDA study that Professor Gansevoort has been instrumental to start, looking at registry data of 4,300 COVID-19 infected patients compared with controls who are also dialysis and transplant patients, showing here a very high increase in risk of mortality in both transplant and dialysis patients, especially in the elderly and in male dialysis patients. So at least in my country, it's been, the discussion has been, well, they would probably have died anyway because, you know, they're sick and old and all this, but it's not true. They, compared to patients, the control patients who had an expected mortality 1.2%, 20% of patients receiving dialysis died. And also for the kidney transplant patient, there's also a very high number as compared to the expected mortality. And actually in the kidney transplant group, over 75, almost 50% did not survive COVID-19. So the question is mortality higher in patients on dialysis or in transplant? And this is a slide I received from Professor Gansevoort, looking at different models with hemodialysis being the reference. And here it was shown that the kidney transplant patients actually had a higher mortality if you combined the frailty and classical risk factors for COVID-19 death, including obesity, hypertension, diabetes, heart failure, COPD, and smoking. And we can discuss this later. So to finalize this talk about the dialysis patients and transplant patients, of course, they should be prioritized for vaccination. They're a very vulnerable population. The dialysis patients have to often go to these in-center dialysis units. And if these are prioritized for vaccination, you may have a risk of reducing mortality, infections, and the healthcare burden, which is very high. So my two final slides are about specific vaccine-related issues. So the choice of COVID-19 vaccine in CKD, does it matter? In dialysis, transplant, this will be discussed by Professor Gansevoort. So I will only discuss patients receiving immunosuppression for immune-mediated kidney disease or vasculitis. And there's not enough information really on this subject. We know that patients with glomerulonephritis and vasculitis are a risk population. Glucocorticoids, especially higher doses, and rituximab increase risk for severe COVID-19. There is a specific problem with rituximab, which leads to rapid and prolonged B-cell depletion, which then affects the antibody response, which has been previously shown with influenza vaccination. So most clinicians will try to tailor maintenance treatment and likely delay additional doses of rituximab. And it has been suggested that a minimum 6-month waiting period after rituximab treatment before vaccine, and perhaps you should follow B-cell repopulation to be more certain that there be a good antibody effect, and perhaps also serology monitoring and readiness to administer booster doses if this is what is recommended in the future. But also to remind everybody that safety measures such as social distancing and using personal protective equipment is equally still important. And my final slide is trying to raise this question of vaccine hesitancy. And this is a problem that is may differ by socioeconomic and demographic factors. People have various health literacy. They don't really understand this. There's a lot of information around in social media, on television. Patients worry about side effects. They worry about trigger for relapse of their disease or rejection, all to conspiracy theories about 5G and Bill Gates injecting DNA material in people. But I think we are in a unique position since we have this long-term relationship with patients, and we should enable balanced discussions of the benefits and risk and uncertainties, and we should use that to convince patients. And we should also refer patients to reliable online sources if they start sharing things that are not really true. And these are some links to reliable sources, and also two papers we have written from the Immunopnephrology Working Group of the ERDA regarding this subject. Thank you.
So thank you, Professor Bruchfeld, and thank you, Anette, for this nice overview, really, and thank you also for the really recent literature, even papers from this month. So this is great for the audience, and I'm sure the audience will appreciate this and will have questions to you. And I also encourage the audience to write your questions in the question field, which is on the right bottom of your screen. So we will answer your questions at the end of the second talk now. And we will hear now from Professor Ron Gansevoort the title COVID-19 Presentation in CKD, an overview of the data thus far. And Ron, please, you are among the pioneers in the ERA, EDTA field and overall with your initiatives. So very keen to hear your view. Please.
Yeah. Thank you, Christoph, for this very kind introduction and also for your invitation to give a presentation here. And I'm supposed to talk about COVID-19 vaccination in chronic kidney disease, an overview of the data thus far. And I will show you data also of our Dutch RECOVAC consortium that we established to study the effects of vaccination in patients with chronic kidney disease. And this slide is a summary of a study that also was discussed by Annette just a minute ago. It shows you the data of the Open Safely study, health analytic platform from the United Kingdom that covers almost 40% of the NHS patients, and it included 17 million people, among which almost 11,000 COVID-19 related deaths. And what you see here is the fully adjusted hazard ratio, and looking at all kinds of risk factors for mortality related to COVID-19. And on top are the nephrological risk factors. So first, the patients with slightly impaired kidney function, GFR between 30 and 60, GFR less than 30, patients on dialysis, and patients living with a organ transplantation. And here below are the classical, more well-known risk factors. These are hypertension, obesity, chronic heart disease, diabetes, etc. And what you can see in this slide that it are in fact chronic kidney disease, and especially the dialysis transplant patients and more severely impaired kidney functions that have an extremely high mortality due to COVID-19. And these factors are more important than the classical risk factors that we always hear about in the news, but in fact are less of risk factors than chronic kidney disease. So given these data, there is a high need in the kidney field for effective vaccinations. And what do we know about vaccinations in chronic kidney disease? Of course, we know that in later stage chronic kidney disease, so the stages 4-5, hemodialysis, transplantation, there's less efficacy of vaccinations due to uremia and the use of immunosuppressive agents. And that holds for hepatitis B, for influenza, but also for pneumococci. And because of these vaccines are less efficacious, we tried everything to improve the immunization rate and the efficacy, and we have investigated various strategies. For instance, adding repeat vaccinations, changing the injection mode, but also adding immunostimulants to improve the immunogenicity of existing vaccines. And here in this slide, I show you now the first results of COVID-19 vaccine studies in patients with chronic kidney disease. And on top, you see the studies performed in hemodialysis patients, all relatively small-scale studies. And they show that after 2 doses, and in most cases it was the Pfizer vaccine, that seroconversion rate was quite good, and it ranges between 80% and 96%. That's not bad. But when you look at the kidney transplant patients, that is here below, again, 2 dosages, most often the Pfizer vaccine, but also Moderna was studied, and there the response is different. It is less impressive, and it ranges between 6% and 48% response rate. These are all indirect comparisons between dialysis and transplant patients. And there have now also been a couple of studies that looked at kidney transplant patients and patients on the waiting list to be transplanted, so hemodialysis patients, and then they looked at the effect of 2 dosages of Moderna or Pfizer and assessing the day 28 seroresponse. And what they noticed that in the dialysis patients, again, quite a good results, but in the kidney transplant recipients, it was a very low seroresponse rate, 90% versus less than 10%. Small numbers though. When we see this kind of results, I think it's better to vaccinate first than to transplant. This study looks at the influence of different types of immunosuppressions. And this on the left is Celcept, or mycophenolate mofetil. And the patients using MMF had very low seroresponse when compared to patients not using Celcept. There is also such a response seen for prednisone and for calcineurin inhibitors, but it is especially present not only in this study, but in several studies for Celcept. And really Celcept seems the agent that is doing the really bad job in transplant patients. When looking at calcineurin inhibitors, it was investigated patients not using a calcineurin inhibitor, patients using cyclosporin, and patients using tacrolimus. And there was a graded dose response that the lowest seroresponse rate was on tacrolimus, and cyclosporin was somewhere in between tacrolimus and not using a calcineurin inhibitor. Again, a study, this time from the Charité Hospital in Berlin, in press, it can already be viewed on the internet. Small scale study again, now the advantage of a control group, a transplant group, and a hemodialysis group. And when you look at the IgG response, the seroresponse, you see the same data that I just mentioned. Of course, a good response in healthy controls, but also a good response in hemodialysis patients, but in kidney transplant recipients, the response is very low. This is the seroresponse rate on average. However, when you look at the IgG levels in these patients, and when you look at the hemodialysis patients, it seems that the response is quite good with more than 80% seroresponse. But when you look at the individual IgG levels, it is significantly, but also relevantly, clinically relevantly lower than in healthy controls. And that is not only the case for IgG levels, but also for neutralizing antibodies. And when you look at spike as one specific IgA response, you see the same picture. Hemodialysis patients slightly impaired response, lower levels though when compared to controls, but a very bad response in the kidney transplant recipients. These were most times indirect comparisons and also small patient groups. And that's the reason why we in the Netherlands started the RECOVAC consortium. And this consortium is doing a number of studies. And this is what we call the immune response study, in which we, in 4 cohorts and in 4 centers, Groningen, Rotterdam, Amsterdam, Nijmegen, are studying healthy controls, patients with CKD stages G4-5, hemoperitoneal dialysis patients, and kidney transplant recipients. And these are larger numbers ranging from 175 to 300. Patients are vaccinated on baseline and after 1 month. And then at day 28, we have got measurement of our primary endpoint, IgG seroresponse, but we'll measure it also at day 180 and day 365. And besides the IgG seroresponse, we will also measure the durability of the IgG response. We'll also measure cellular response and safety. And I'm showing you now the first data of our consortium. These are preliminary data and confidential. It's the humeral response, so IgG levels directed against the spike 1 S1 protein. And on the left, controls, patients with CKD stages 4-5, hemodialysis, peritoneal dialysis, and kidney transplant. And here you see that in the CKD population, there's more variability when compared to control, but it's not significantly different. In hemodialysis patients, there you see it coming, that there's an impaired seroresponse, but that impaired seroresponse is especially present in kidney transplant patients. The data you have seen all hold to the humeral response, but also the cellular response is of course important, the cytotoxic T cells, and that is the first data about the T cell assay. And again, looking at healthy controls, CKD, hemodialysis, peritoneal dialysis, and kidney transplant recipients. And you can see here that the cellular response is quite good in all the patient groups, but that especially in the kidney transplant recipients, it is impaired. When you look at the individual responses, it's like the sero response, that although in hemodialysis patients, the response rate looks good, but when you look at the individual levels of the T cell assay, it is lower actually than in healthy controls. And we have to await what will happen with the efficacy of vaccination in these patients. This slide shows you how well the humeral and cellular response correlate. And here on the x-axis, I show the cellular response for the different patient groups. And here on the y-axis is the humeral response. And when there is a good correlation, patients should be either in this quadrant or in this quadrant, because then you have a good cellular response and a good humeral response. And indeed, there is a good correlation. Patients with a good with a cellular response, the patients with a good humeral response can have no cellular response. And that is what we always hope, that patients that would not have a good humeral response, then T cells would kick in, but the first data suggests that this is not the case, that in the patients that especially also cellular response might be impaired. Of course, we don't know then how effective vaccination will be. That are all indirect data, but now the first data are coming in, and these are reports of this week, one from the United States, from New York, Baltimore, describing 14 patients with a solid organ transplant that were diagnosed with COVID-19 after 2 vaccinations. And there's another study, a larger study from France, multi-center study, 55 kidney transplant recipients diagnosed with COVID-19 after 2 vaccinations. And what we can learn from these studies is they were diagnosed at a median of 23 days after the second vaccination. So that should be good enough to have a good vaccination rate. But still, these patients were infected and 50% were required to be hospitalized. In the United States study, 7% died. In the France study, 27% were needed to be hospitalized, 11% were admitted to an intensive care unit, and 5% died. These figures are better figures than in the untreated, unvaccinated situation that Anette just showed you, because their mortality is around 15 to 20%, depending on the study that you see. And the first reports that we now get from COVID-19 breakthrough is that mortality is around 5 to 7%. And I think it also shows you that there is a kind of surrogate for efficacy of vaccination, because in the French study, there was also data available in 25 patients about IgG levels after the second vaccination. And it was shown that 24 out of the 25 patients that there were information on IgG level, that these patients were actually seronegative, so that they did not respond to vaccination. So I think that especially our kidney transplant patients will have a problem in the future. And that's also what we are investigating in the RECOVAC-2 study, where we are investigating whether IgG response is a valid surrogate for protection. And we do a very large scale nationwide study looking at the national registration of COVID-19 vaccination, and we do a record linkage with the existing national registries of kidney transplant recipients and dialysis patients, and we are then measuring the percentage of patients with a COVID-19 breakthrough. Not only that, we are also going to measure the IgG antibody levels, and we will do so in large numbers of patients, in 4,000 patients with CKD stages G4, G5, 4,000 transplant recipients, and 4,000 dialysis patients, and then we can investigate what IgG levels mean as a kind of surrogate for vaccination efficacy. We will then also identify a large number of non-responding CKD patients, so transplant patients that did not respond to vaccination. What we would like to do in our third study that we have just started, the RECOVAC-3 study, which is a booster study in non-responding CKD patients. In patients on triple immunosuppressive, we are going to continue CellCept, so mycophenolate, or we are going to stop mycophenolate, 60 patients per arm, and then look what Moderna 100 microgram, a third and a fourth booster will do. In patients on dual therapy, we are going to randomize them either to a third and fourth booster with Moderna 100 microgram, or give them also 20 microgram intracutaneously, use a higher dosage of the Moderna vaccine, or do heterologous vaccination with the Johnson & Johnson vaccine. Again, looking at IgG response, but also at cellular response. And this brings me to my conclusions. I hope that Anette, but also I, have shown you that COVID-19 related mortality in dialysis and transplantations patients is exceptionally high. And the first vaccination data are not comforting. Especially in kidney transplant recipients, the vaccination or seroresponse is low, and there is probably especially a role of the use of mycophenolate, CellCept. Less than 50% of kidney transplant recipients actually had an adequate seroresponse. And whether the seroresponse is a good surrogate for protection is not known yet. But we know, of course, that the cellular response is also important. But these first data also suggest that in kidney transplant patients, there is not an adequate cellular response. And not surprising, given these reports, there are also now reports of breakthrough COVID-19 infections in kidney transplant recipients, especially in patients that had an inadequate seroresponse and an inadequate cellular response. And I think that specific vaccination booster studies are now urgently needed. And I thank you for your attention.
Thank you, Ron, Professor Gansevoort. This was really an effort. My impression is if you lose track for a month, you are overwhelmed with new data. So very timely and very, very good effort indeed. So we will move to the questions we received from the audience. And I would like to ask the studio, which are bringing forward to me the questions from the chat. And you still can ask questions, just type them into the question window. So here is the first one, and Professor Bruchfeld, I will read this. How should the multidisciplinary post-COVID care best be organized?
Okay, thank you. This is a very interesting question. I have a sister who is an infectious disease specialist, and she has set up this kind of clinic. And they really have everybody, the pulmonologist, the cardiologist, they have physical therapy, the infectious disease specialist, nephrology is there, and they meet the patients together after they've done a certain test procedures. They some of them they can send back to primary care, but other patients they have to follow, and there are quite a substantial number of patients who have this POT syndrome, that they will have a postural hypotension, which is a really severe and debilitating symptoms. But I think you should organize it with specialists and follow these patients. This is a new disease. It's not the flu, it's something else. It's a coronavirus, and we will learn a lot. And I think perhaps in the future also learn a lot that will help us even for other diseases. But it's good if you have some research interest and try to follow that as well in these multidisciplinary clinics.
Christoph, do you allow me to
thank
ask
you.
also?
Please, yeah, give us your perspective. Yes.
No, I don't know. It's a perspective, but more a question. Is this post-COVID syndrome now something that is really specific for COVID? Because we have seen it, of course, also after other viruses, like Q fever. We've got Lyme's disease. So is this more a kind of general syndrome that can be seen after severe viral infections, or would it really be something specific for corona? Do you know that, Annette?
No, I think that this remains to be seen, but this is, I think some things will be more specific for COVID, the neurological symptoms, things like that are really strange things, and the loss of taste and smell and things like that. But since it's such a massive burden on healthcare and all these patients are there, of course, it's easier to study this phenomenon, irrespective of what we will find. Any information is interesting, but I think that eventually there will be more specific things for this viral infection as compared to other. I'm very experienced with hepatitis C as an autoimmune virus, and this is also considered some type of autoimmune virus, giving this really strange multi-inflammatory syndrome in children, also in adults. There are many disease manifestations, but we will see. I mean, we will see when we have the data and can compare on a different level.
So let's add me a question in this respect. Is there a post-COVID, long COVID syndrome, kidney syndrome, when you not only look at eGFR, as in this Lancet paper, but also look at albuminuria? Are there data on albuminuria in the long term after 3 months, 6 months? Because albuminuria is seen quite often during active COVID infection.
Yeah, that's a very important
question. Any data?
I think there's very little data, but I know that a lot of people are studying this because it seems that most patients will recuperate and gain kidney function. But I thought this Chinese study was really interesting, looking at patients who didn't have AKI and normal EGFR, that they had reduced EGFR after 6 months. And we are collecting data for new kidney disease in international registries to see if we can see if this viral infection will trigger some new kidney disease. And this also has to be followed very carefully through registries. But I don't think there is anybody that really collects that there is data as of yet.
And it may seem in the first reports that there is a good recovery after acute kidney injury, but I think there are two important aspects. It seems that kidney function recovers well, but we measure it, of course, with creatinine, and many of these patients have lost quite considerable muscle mass. So when GFR is near the pre-COVID level, is that actually a reflection of similar kidney function? I do not know. That's one aspect. Second aspect is, of course, as we also know from acute kidney injury, that you can lose nephrons. And because of your functional reserve capacity, it seems that your kidney function is still perfect, but in fact you have lost quite a considerable number of nephrons, making you at risk for chronic kidney disease at the longer term. And that is something to be awaited and to be studied in the future.
Can I ask you a question around I was thinking about the picture you showed on the patients, the dialysis patients who their response to vaccination, and you could see that they had a fairly good, but there was a group that didn't have a good response, that were more similar to the kidney transplant patients. Are these patients on immunosuppression? Because we have some dialysis patients who are on chronic immunosuppression.
We haven't in our study looked at that level of detail because these were data that we just got a couple of days ago. We have to look into that, but it indeed seems there's a kind of subgroup, and whether that subgroup is characterized, for instance, by the use of immunosuppressant at present, or in the past has to be studied. And also, but in the kidney transplant recipients, it looks whether there are kind of three groups when you look at the IgG levels. One that is nearly normal, one that is a kind of normal distribution, so a Gaussian curve with an impaired, and there's a group with no seroresponse at all. And these are using the same level of immunosuppressants. So what is causing this kind of three-phasic pattern, I don't know.
Thank you.
Great. I think I do not have to apologize to the audience that you have this high-level expert discussion among you. It's really great. Anyway, I ask the studio to bring forward the next question, please. And this is to Professor Gansevoort. A patient who needs desensitization treatment before transplantation received rituximab 3 months ago, just at the stage of acceptable antibodies. Should be first vaccinating, although retux is at the 3rd month?
When this is a kind of planned procedure, of course, try to vaccinate before you give any immunosuppressant, and especially rituximab. Because after rituximab, especially in the first couple of weeks, first 3 months, there will be no antibody response whatsoever. And what I personally do now, I postpone when possible the next gift of rituximab. So normally I give it once every 6 months, but now I postpone it to 9 months and just in the end phase give the vaccination. Whether it is important, I don't know, because people with rituximab and only using rituximab have quite intact cellular response. And I've got a couple of patients that were on rituximab and had COVID-19. Personally, I felt, oh gosh, now they'll die. One of them even called me, telling me I want to say goodbye because I'm going to die. But he didn't even make it to the hospital. He was not ill at all. Apparently, his T-cell response was in that good shape that he could cope with a COVID-19 infection. Will be different in transplant patients because these are not using only rituximab, but will then also use all other kind of immunosuppressants. So then you have a completely abolished seroresponse and a very low cellular response probably. So these are the really high-risk patients.
Your response is important because we have a lot of vasculitis patients which are on the maintenance rituximab and for 1, 2, 3 years even. And I think we have to respect this, what you are saying. Annette, you had something.
Yes, I had a comment. So we have looked through our vasculitis cohort, almost 300 patients, and we have our reflection so far is that the patients that do really badly are the one with induction treatment and COVID at the same time or very close in time, and we have seen the deaths there. But we are now looking to see how well they manage the ones only on rituximab maintenance therapy. Maybe that's a different story. And
a different way of handling this problem. These people that don't show a good seroresponse, especially when you know that they are using rituximab or other immunosuppressant, is ring vaccination. So normally we would not easily vaccinate children, but many of these patients have children that are not allowed to go to school or not to see other children because their parents are afraid for COVID-19 infection with their children, that the children bring it into their homes. But it might be an idea for ring vaccination so that all people around these patients are vaccinated, including children. And that we now get the messages of the European Medicines Agency that the vaccines have a excellent safety side effect profile in children, makes this a new option, ring vaccination.
So let's go to the next question. I ask the studio, and they bring some up for you both. So please comment on mixing different vaccines on different doses or as booster. So ladies first, please.
Yeah, this is a very interesting concept, and it's been accepted wide. That myself, I was vaccinated today with Pfizer vaccine, and I started with AstraZeneca. So it's an interesting concept, and I think perhaps if you don't get a response from one vaccine, it may make sense to try something else. All of these vaccines are really safe. I mean, of course, there's the story of AstraZeneca with the increased risk of thrombosis, but for most patients, I think combinations are possible. But I think these studies that Professor Gansevoort described, these booster vaccine studies are really important and will help us in the near future, I hope, to know what to do with our patients and what to tell them.
Yes, studies have not been published yet about efficacy, but there is a famous study from the United Kingdom, and they looked at the side effects of heterologous vaccination. So switching from a vector vaccine to a messenger RNA vaccine, and they showed that there were more side effects when you boosted with another type of vaccine instead of boosting with the similar vaccine. And that suggests that there is a more active immune response. And hopefully this will also result in a better seroresponse, so better protection. But these data have not been published by the UK group yet.
No.
I know from other experimental data that it also seems that the messenger RNA vaccines have a better seroresponse, whereas the vector vaccines may perhaps result in a better cellular response. And that would also give us some kind of theoretical background to do a heterologous vaccination. So changing from vaccine when we are boostering.
Yes.
What is the current status of the booster concept when you are successfully vaccinated twice? Is it 6 months or what are we discussing currently?
We're not. I don't know if there is any. I think we have no. I mean, it seems like most people who have a good response, they will have a good response for a considerable amount of time, and this has to be followed. But our patients may have a lowering degree of antibodies, and we need to follow them. That might be a bigger problem than the healthy general population.
Yeah, the durability of the seroresponse has not been studied yet in the general population, so when to give a booster, but there are now various countries across Europe that are thinking about booster studies. So the United Kingdom, who were of course one of the first for complete vaccination of the population, they're thinking about boostering. And in France, in fact, all patients that are immunocompromised, it is advised already now to do to give them a booster.
Yeah.
And that's the first country in Europe giving this advice. Whether that is a good advice, we don't know. And I would prefer that we first do studies looking what the seroresponse is and what the efficacy is of a booster vaccination. And how valid a seroresponse is as a surrogate for protection against COVID-19 infection. But we are now entering this era of uncertainty when to booster and whom to booster.
So there was a study published yesterday in the NDT from Toulouse. They looked at 109 hemo and peritoneal dialysis patients, and the antibody response or serological response was in 97 of those patients. And then they had 12 patients who didn't respond. And then they also looked at the factors that could affect this, and these were more patients on immunosuppression and had a strong effect. And then they gave them another booster. I think it was Pfizer or Moderna, I don't remember. And 5 of those seroconverted, but not all of them. So we are in this new era where we have to think further along and plan for the future in a different way than we thought.
So what do you recommend to owners? What do you recommend to owners of dialysis center to monitor zero response every year in the entire dialysis unit, or what is the recommendation?
We don't know.
So far, cannot be
I think
answered.
I would certainly check the antibodies in dialysis patients who are on immune suppression. That would make sense. I don't know if you should check it in everybody. It's a cost, and we don't really know what to do with the result. But I think that these studies that are conducted in the Netherlands, and also what is going on in I think Moderna is doing a study in Canada with a booster vaccine. I think we will learn more in the next 6 months what we should do. So I think that it's difficult to recommend anything at this moment.
At present, I would
So
not
let's have
measure
the
the
next.
seroresponse in hemodialysis patients, only in a research setting, unless we know more. Again, know more about what the effect of boostering will be. When boostering has no effect, there's also no reason to measure a seroresponse.
No.
Probably we'll have to remeasure, but what time interval, I really wouldn't know.
Yeah, and I would say that
I
it's
like
really.
this answer.
I think it's really
I like
important
this
also
answer
to.
because this is a scientific one.
Yeah, and I think it's really important to remind people this thing about the ring vaccination, that we are all dependent on each other. So it's important that everybody is vaccinated to protect the vulnerable, as it always is. And we have to remind people about that. It's not only about your health or your vaccine, it's about everybody else. It's like being solidarity is important.
Yeah, but it's an ethical problem, of course, Annette, whether we're going to vaccinate children. Normally we wouldn't do, but in these cases of highly vulnerable people, it might be a real issue to do vaccinate these children, not only because that might benefit our vulnerable patients, but also because these children are kept at home, not going to school, not seeing other children. And when you do vaccinate them, they would be free again to go to school and to have their normal lives again.
So there are many more questions. I think we have to go fast now and shorter answers. The next one is, does sex or BMI affect immune response after vaccination in kidney transplant patients? For Ron.
Not known yet. That's short.
Good. Next question. Yeah, that's good. Is the duration of protection post-COVID vaccination in CKD patient as normal or shorter?
Yeah, I will cite Professor Gansevoort. Not known yet, needs to be studied.
No, actually it's not known yet, but we expect it to be shorter. Yeah.
Yeah, most likely, because it usually is.
This goes into the direction that we have to study.
It has already been shown for the seroresponse after COVID-19 infection, that in CKD patients, IgG levels decreased faster than in healthy controls. So that's an indirect evidence that probably also vaccination will last less long than in healthy controls.
There is always a delay between your home and me because the message goes to the moon and back, and this takes 3 seconds. So I realized this. Next question, please. There are messages in literature that the vaccine may decrease GFR. What is your opinion about this issue?
I haven't read it in literature, and I don't believe it. I don't think there's any evidence for such a thing. And when patients ask us, is it safe for me as a kidney patient to take a vaccination? It is safe, and it is highly advised. They are the most risky group there is for severe COVID-19, and until now there is no indication for any specific adverse event in this specific patient group.
I agree.
So we take the next question, yes. COVID vaccination non-response. what are your recommendations right now? Wait for study results or boost the dose for non-responders, poor responders with low antibody levels?
Annette?
Yeah, I think we should wait for studies, but I think perhaps if you have a hemodialysis patient that doesn't respond and will be transplanted, it would perhaps make sense in that person to have a sort of more personalized approach to make sure that they are more protected, and then you could consider booster doses in those. But I think we have to wait for the data from studies.
Yeah, I think I like that answer, Annette. I hadn't thought about it, but indeed, before starting dialysis or before transplanting, so when you have a shift in your renal life cycle, measure an antibody response, and whether it's insufficient, then booster. Same may hold when you have time before you start immune suppressants in a specific type of kidney diseases, to get them in an optimal shape for a good vaccine response.
Yes.
So personalized response until further data come for the larger group of patients.
Very good. Next question, please. It seems that transplant recipients with suboptimal graft function may even do worse. The question is, does it make sense to take these patients back to dialysis earlier than just suggested before?
Make worse with vaccine or make worse in general? I'm not sure what the question is.
Yeah, with the zero response to vaccination.
Okay.
Because it's the adding the immunosuppressive effect of uremia together with the immunosuppressive effect of the drugs they are using. So taking them on dialysis earlier and then waning the immunosuppressants that they're using will probably give a better seroresponse. But being on dialysis itself has such bad effects. The chance of getting COVID-19 are higher because you have to travel more.
Yes.
And there are, of course, far more kind of complications in these patients.
Yeah. Yes.
So
it's better to.
If you ask the patient, I think they don't like this question.
No. They don't like this suggestion. No, they can still shelter.
Yeah. Do we have more questions? One more, please. So vaccinating a patient post-COVID infection, by when can we give rituximab? 1 or 2 months later?
Yeah, so we wrote a recommendation for patients who are on the rituximab treatment that was published now in May in NDT. So we think that you should wait at least 4 weeks after the second dose, because you give a chance for the antibody response to occur. But then also this question of patients who already had COVID. This is an interesting question. The recommendation now, at least in Sweden, is to vaccinate everybody, but you can wait 6 months after infection. But it also depends on how the antibody, I mean, if it's CKD patients, they might have a shorter duration of protection. It seems women have their antibodies go down faster than in men. So it's a really complicated question, but you really need to discuss this carefully. But protect your patients the way you can. And for rituximab, at least wait another 4 weeks after the second dose, vaccine dose.
Yeah, and I'm not going to discuss rituximab, but when you have had COVID-19, in the Netherlands at least, the general advice is that only one vaccination will be sufficient.
Yes.
However, I think when you are a CKD patient on dialysis or a transplant, it should not be one vaccination. There you should at least have 2 vaccinations. Yeah.
Yes.
So we never had in the past webinars so many questions from the audience, and this was really a lively discussion. And it was a pleasure for me to talk to two counselors, one previous and one active counselor. Actually, Anette, you received also a diploma from the ERA EDTA. I see it in the back of Ron Gansevoort's room, but not in the back of your room. So you should improve this.
Yes, exactly.
A bit.
I have it in my room here in Linköping, so I feel more at home.
So anyway, thank you. This was excellent. And thank you for your active and really good contribution. Bye-bye.
You're welcome.
So I also thank the audience that you really participated so actively. I would like now to introduce, actually this is myself, no, it is Adira Levin. She is speaking to us from Vancouver, Canada, and she will bring the recent findings of new CKD treatment into perspective for entire nephrology. She is the former ISN president and has really a good overview about the topic. Myself, I will do the recent results in the field of diabetic kidney disease and even also the perspective for our patients in the future. And then I want to remind you that we are now coming close to the end of the 18th webinars. Next time we have number 16, so there are 3 more to go. But we come close to our Congress in September. It is September 14 to 18, actually 15 to 18, and will take place virtually. I'm invited to the studio to moderate from Frankfurt studio and bringing to your home very interesting discussions from 67 speakers which are convening during these 3 days and discuss really recent advances in the field of nephrology. So please note this in your calendar, Live 2021 Nephrology Congress, which will take place September 15 to 18. And I wish you a remaining fruitful day. Thank you.